We are live on YouTube. Thank you, everyone. Have a great meeting.
Thank you, Ted.
Good afternoon, everyone. I'll give folks just a few minutes to join us, and then we'll begin. Well, good afternoon, everyone. I'm Jennifer Sullivan, Secretary of the Indiana Family and Social Services Administration, and thank you for joining us for the Summer 2021 Non-Emergency Medical Transportation Commission meeting. Appreciate everyone's participation and passion around this very important topic. We have so many really exciting updates for you today around this work within Indiana Medicaid. And I would like to welcome you all to today's discussion. Today's agenda, we will start with a welcome and some introductions, and then Lindsay Lux will give us program updates, and Jim DiGlimberto from SET will give us a performance summary for SET. We'll talk with Elizabeth Darby from Indiana Medicaid around our pay for outcomes review. And then we'll have open discussion and vote on those P4O processes and then adjourn. So looking forward to a full agenda today. And again, welcome to all of our commission members who are here. I'd like to quickly take roll for those commission members that we have with us today. We do have a vacant position of a fee-for-service member that we are actively engaged in looking for putting that fee-for-service member who is a recipient of NEMT services back onto the commission. So we'll have that filled by our next commission meeting. Sarah Chestnut from INARF.
This is Philip Parnell from INARF. I'll be filling in for Sarah today.
Thank you, Philip. Welcome to today's discussion. Dr. Michael Kaufman from Department of Homeland Security.
Good afternoon, Dr. Sullivan. I'm here and accounted for.
Thank you. Gary Miller from Prompt Medical Transportation.
I'm here.
Thank you, Gary. Andy Van Zee from the Indiana Hospital Association. Jim DiGlimberto from Southeast Trans.
Good afternoon.
Hi, Jim. Kim Dodson from the ARC of Indiana. James Fry from Steadfast Transportation. Sherry Hampton from American Senior Communities.
Hello, I'm here. Thank you.
Thank you, Sherry. Kristen Lais from I4A.
Good afternoon, I'm here.
Thank you, Kristen. Amanda McClure from Fresenius Kidney Care. Jennifer Sullivan, here and accounted for. Representative Jim Pressel from the House of Representatives.
Here.
Good morning, Representative Pressel, or good afternoon. It's good to see you. Representative Mitch Gore, a new member from the Indiana House of Representatives. Senator Vanita Becker from the Indiana Senate.
Good afternoon, Dr. Sullivan.
Good afternoon, Senator Becker. It's good to see you.
Okay.
Senator Jean Breaux from the Indiana Senate. Okay. Thank you all for being here. and we will move to the next slide, please. So it is with great excitement on behalf of the Indiana Family and Social Services Administration and Governor Holcomb to introduce to you the new FSSA Secretary, Dr. Dan Rosiniak. Dr. Rosiniak will begin his role on August 1st, 2021, and will move into this now very empty office on Monday morning. As I depart on Saturday from this role and moving to North Carolina, I will be taking a new role with Atrium Health as the Senior Vice President for Strategic Operations. This is a very exciting and yet very bittersweet move for me. It has been the honor of a lifetime to serve as your FSSA Secretary and try to help move the way that we think about the improvement of health outcomes for Indiana's most vulnerable forward over the last 4.5 years under the leadership of Governor Holcomb. Dr. Rosiniak is currently our Chief Medical Officer at FSSA and has held this role for a little over 3 years. Many of you have seen him with his media fame over the pandemic response as Dr. Dan. He led the long-term care response for COVID and did that extraordinarily admirably and saved many lives with his thoughtful, wise approach to improving safety and security for individuals receiving services in long-term care facilities. And I'm so excited to welcome him into this role at FSSA, and I hope that you will as well. So thank you and welcome to Dr. Dan. So I will turn over the agenda to Lindsay Lux, who is one of our executives within Indiana Medicaid, and NEMT is one of her many things in her portfolio at Medicaid. And so Lindsay, you can take it from here to talk about program updates.
Thank you, Dr. Sullivan. If you'd like to, there we go. So NEMT services are permitted when a member is traveling to Indiana Health Coverage Program providers or Medicaid providers, including pharmacies, et cetera. However, with the COVID vaccine rollout, there were many locations providing vaccines that are not your typical provider location. We instructed SET, and they worked very quickly to ensure that all vaccination locations were acceptable provider locations, and they are providing transportation to any members seeking a vaccine at the location of their choice. Next slide. Our Division of Aging partners operate 2 Indiana Medicaid waivers. Historically, those waivers permitted members to be transported for NEMT by their waiver attendant care provider. However, our waivers are only able to provide services not otherwise covered by Medicaid. Due to the duplication of service and without CMS approval to do otherwise, we notified providers that this transportation would also have to be run through our NEMT broker. This was understandably upsetting to the waiver members who have long established relationships with their waiver care providers. So in talking to some providers and members, we understood that the attendant care providers were providing more than transportation services, but they were helping the members throughout their appointments. For example, helping to ensure that the members understood their care plans. So in an effort to ensure coordination of care for our members, we were able to receive CMS approval to provide the service within the waiver during the public health emergency, and we will be applying for that to continue permanently. Next slide, please. Indiana 2-on-1 became part of FSSA in 2020. They, in partnership with the Division of Mental Health and Addiction, wanted to provide transportation to individuals seeking substance use disorder treatment. This transportation needed to be available almost instantly when an individual would call, so they partnered with SET and Lyft to make that happen, though it is separate from Medicaid transportation. So we're really excited that we were able to also add this transportation service to the portfolio. I'd like to go on to the next. I'm going to turn it over to Jim Degliamberto, who is the Chief Operating Officer for Southeast Trans. He's going to walk you through some Southeast Trans performance and also network adequacy. So Jim.
Great, thank you, Lindsay. And thank you for the opportunity this afternoon to speak to you about the program. Dr. Sullivan, thank you for your support over the last few years. Best of luck in your new role. And Dr. Dan, looking forward to working with you in the future. So by the numbers, you can see here that we are looking at call center requests per day, average calls handled per day. I just want to touch on a few of these numbers, talk a little bit about how the pandemic has impacted them. Call center numbers are down roughly 25% due to the pandemic. We've also reduced a number of call center agents in our call center here in Indiana as a result of the decreased call volume. We're down roughly 26 or so agents due to the decrease in call volume. We're still meeting the call center metrics. Obviously, just with less calls, we need less call center representatives to answer the phones. On the claims side, still receiving a good number of claims. Roughly 2.8% of those claims are denied. That's the 3,700 number you see in the fourth quarter. 2.8% of that 36,000 claims it's a pretty low number from us, from SET enterprise-wide. It's a little bit over 3%. So Indiana overall has a lower denied claim rate than our industry as an average. And again, with denied claims, it doesn't mean that it ends there. Providers have the ability to fix a denied claim and resubmit that claim for readjudication. There may have been a reason why it was denied or why a claim was rejected, but the transportation provider does have the opportunity to resubmit that claim. One of the things that we worked on this year should be coming out early next year is the ability to resubmit your claims online. Basically fix anything that may have been wrong with your claim electronically and then submit that claim electronically back to our claims department. Today, it's a paper-based process. So we are advancing that and making it easier for transportation providers to, when they do have a denied claim, have the ability to resubmit that electronically. Next slide. So this slide talks a little bit about the trip fulfillments and the types of trips that we're running. You'll see that subscription trips are typically 56 to 57% of our total trip volume. Fourth quarter, we looked at 46,000 one-way trip legs per month. And again, the majority of those being subscription. And your subscription trips are your standing orders are those recurring appointments, such as dialysis or chemotherapy, radiation. Those trips are scheduled in advance and typically recur every 1 to 3 days, depending on the services that are being provided. If you look a little bit further down, you'll see high-risk members. Those high-risk members are typically those trips that are subscription-based. So that number does correlate because your high risk, your dialysis, your chemo, those typically have recurring appointments. When you look at those trips that are being fulfilled, there's two numbers that are listed. One is the total fulfilled trips, which averaged about 86% in the fourth quarter. The number below that 95.4%, that is the fulfilled trips when you pull out member cancellation type reasons. So looking just at the transportation side of it, taking out any member no-shows or member cancellations. For instance, if a member is in the hospital and cancels their trip, that shows up in the 86.39 number, but not in the 95.4 number. So that number, that 95% fulfilled, is right where we are corporate-wide as well. We average anywhere from 94 to 95% total fulfilled trips enterprise-wide, and Indiana is right in line with that. Looking at active drivers and active vehicles, you'll notice that number is down from last year. And the big reason for that obviously is the pandemic. We're down about 13% in terms of trip volume from last year. But with the reduction in trips, we'll have a reduction in drivers and a reduction in vehicles. As trips are rebounding, we are actively recruiting providers to come back into the network. But overall, we are down roughly 125 drivers and 78 vehicles from first quarter. Looking at the complaints slide, you'll see two different bars. The green bar being the all complaints as documented within our trip system, and then the blue are the substantiated or validated complaints. Roughly 70% of all complaints are validated. The trend here and what we've seen, and you can see it on the slide here, is the increase in April and May in complaints. We've dug into these numbers. The majority of the complaints that we are seeing, or the increase that we're seeing, are transportation provider network related. Mostly trips that are unable to be fulfilled because of a provider no-show or because of a late send back by a transportation provider that we are then unable to fulfill. And what that means is a provider was given the trip in advance, and we have some auto routing technology, and we also have manual dispatchers who will route those trips out. It's given to the provider in advance, but what a late send back is when that trip comes back to us from the transportation provider, typically the night before, perhaps even the morning of the transport. And at that point, we're unable to secure transportation for that trip. That often results in a complaint. We've seen that increase in April and May. Part of the reason is due to the decrease in drivers and then therefore vehicles. So what we are doing to address that is we're actively recruiting drivers, providers. Our provider relations team is out looking at our existing provider network to grow them and also to recruit. Last month, I met with a provider in Terre Haute and talked to them about some of the concerns that they're seeing as a provider. And we talked about increased operating costs, costs of fuel, labor expense, even maintenance on vehicles is a concern for transportation providers. So all of those things are headwinds to building out the transportation provider network. And those are things that we are addressing actively through provider relations. So we'll get into more of that as we talk about the network in general. But overall, the member experience in terms of member satisfaction, we look at two different metrics. We look at trip scheduling satisfaction, and that is the member satisfaction with the scheduling process. So when the member calls into the call center to schedule a ride, we are evaluating that experience through a third-party survey company. So there's a third party that will reach out to the member the day after they have called into the call center to schedule a ride. They are asked a series of questions about their satisfaction. Overall, based on the data that you see in front of you, we're at roughly 97% member satisfaction with the scheduling process. Next slide. On the trip experience, these are it's a third party, same third party that does the call center surveys, does the transportation surveys. These surveys are performed the day after the transport. And from the data you can see below, we average roughly 4.8 out of 5, 96% satisfaction on the member experience for transportation. Both of those surveys are done roughly 50 per month through the third party. There is also an automated trip survey that is performed the night of the trip. So you're transported this afternoon, tonight. If you've opted in for our automated surveys, you'll receive an automated IVR survey where we then further evaluate your satisfaction with the services. We average roughly 200 of those per day, or about 4,000 a month. So we've scheduled rides, we've performed rides, the claims payment process where our transportation providers are submitting claims into us. We pay on average within 16 days. So submit the claim to us. It takes roughly 16 days for the payment to end up in your bank account as a transportation provider. We are processing the majority of the claims, typically 100%. There's some dips where it drops to 99.7 or 99.8%, but roughly 100% of those claims are processed within 30 days. Just going back to that slide real fast, I just wanted to speak to kind of the difference between electronic submission and paper submission when it comes to claims. There's some benefits, and we try to push the benefits of using electronic devices to record claims as much as possible. And one of the benefits of using electronic versus paper is that the claim gets to us on average about 14 days faster. And the reason why is because the electronic claim is built as the transport is happening, and it's a very simple process for the provider to submit that claim through the provider portal. So they get it to us on average 14 days faster. Then we process that claim because it's already basically pre-processed through an electronic process. We're able to process that about 1 day faster than a paper claim. Paper claims are still uploaded and submitted electronically, but they're uploading a scan of a paper image. We process those trips, and it's only about 1 day longer to process a paper claim versus an electronic claim, but the real takeaway is the speed at which providers who use our tablets get us the claim versus a paper claim. It is on average 14 days faster, which is pretty significant, 2 weeks. All right, next slide. So one of the things we talked about in the last meeting, one of the things that we've been working on is an enhancement for EMS providers and their billing process. And one of the things that we heard through our partners at EMS was that it was difficult for them to reconcile their billing with our payment process. And one of the main reasons was because we provide out of our system a trip leg ID and a trip ID associated with that transport that they've performed. They would have a run number or another patient control number that is embedded into their systems, and those two numbers just weren't talking to each other. So what we did last year was put a process in place, and it sounds pretty simple, but there's a lot of technology that goes into it. But we added some additional fields to our process so that we could then basically just take their run number or PCA number and line that up with our leg ID number, and then provide data back to them in reports that would allow them to match those two up. So joining those two numbers together was an enhancement for paper billing in that 1,500 form process for EMS providers. The other piece that we did and are currently working with a number of EMS providers on is the 837 file integration. And what that is it's a completely electronic interface between the EMS provider and us, where we're able to receive an 837, which is it's an EDI claim file. It's a large file of claims that if you're not a computer programmer, you have a hard time understanding. I have a hard time understanding. But basically, it's how we talk to EMS providers in terms of claims. And we've put a process in place to accept those electronically. We have 4 providers that are part of the pilot right now that we're working through. They're all in different various stages of testing. We have some that are getting set up and working with their billing vendor to submit files to us. There's others who are already submitted files to us. This is just a great collaboration between Southeast Trans and the EMS community to help streamline their process. This process will also increase our electronic billing percentages as more EMS providers use this method for submitting claims. Right, on the transportation provider areas of need, this map looks very similar to the map that we presented last time, and the main reason why is because those counties that are highlighted in green are your more populated counties in the state. So if you look at Marion County or Lake County in the Southwest, you'll see that those are your major population centers. There's a greater need there for transportation providers because there's more members in that area using our services. So we're focusing across the state, statewide, but we do hone in on those areas where we know we're going to need transportation providers. We use trip volumes and send back reasons and unfulfilled trips to kind of analyze those areas and make sure that we're putting the providers in the right area when we're recruiting. Again, where we're unable to fulfill, we also still have our QRV, our quick response vehicles, to fill in those gaps when needed. Next slide. So when we look at filling those gaps and bringing providers into the network, we just wanted to touch here on the provider enrollment timeline. And what we have are 4 boxes here illustrating the process for a new transportation provider to come into the network. And it typically begins with our provider relations manager working with that provider and understanding their interest, where they understand the program and what it's about. We start obtaining some basic information to pre-qualify them to get them into the network. The next 2 steps are the Department of Revenue process, where you get your motor carrier certificate, and the IHCP process. Those are out of our control and are just part of the state process. The final step, once you get through IHCP, is to come back to Southeast Trans, where we go through our compliance process, where we do all the driver training, the documentation review. We inspect vehicles, we talk about claims, we do the provider orientation, all of those things that are needed as a transportation provider to understand the whole process. So we understand this is a very long process. When you look at areas of need and we want to get providers into the network to serve the members, and you look at a chart like this and add up the days, and it's close to half a year when you add them up, and you look at holidays and things. I mean, it adds up. There are two areas where we're focusing on to compress that timeline. Obviously, in the beginning, we're making sure that we're recruiting providers who we feel are going to be a good fit for the program. And our provider relations managers are upfront and honest with providers when they come in the door. We make sure that we set expectations so everybody is understanding what they are getting into as part of this program. The second half of that is the compliance side, that 45-day window where we are doing the background checks, doing the inspections, doing the training. And a lot of that now we've put online. Part of it was due to the pandemic, and part of it is just normal process efficiencies where we are using tools and technology to make the training process faster. We have an online training platform, a learning management system that is in use for some of the training material. Some training is obviously still in person, but some training can be done online. We're also looking at where we have portals in place to obtain information from providers easier, so that there's less paperwork going back and forth. So where we can control this timeline, we are looking to find ways to make it as efficient as possible to ensure that we can get providers into the network as quickly as possible. So next slide. So talking about providers and who's coming into the network, from a new transportation provider perspective, there's 9 credentialing as of June. Nine credentialing as of June. There's roughly 82 providers interested. They're in what we call our pipeline. They have an estimated capacity of about 95 vehicles, which is a great number. Kind of brings us back to where we were last year, before some of the fallout due to COVID. We had an ambulatory provider begin, a pretty large one, last December that's got 5 vehicles located throughout the state, strategically where we need them. They've also committed to bringing in additional vehicles as needed. The big one there is wheelchair. Wheelchair providers are in need, and those are the ones that when you come into the network, that's one of the things that we're asking about is, are you bringing wheelchairs? Can we get you a wheelchair? Can we bring on wheelchair providers? And we have one coming into Indiana very soon. I believe they've just passed IHCP certification, so now they're into that 4th box where they're starting to go through our compliance process. But when we look at focused areas of recruitment and areas of need, we're not just looking at the state and the area in the state that we need providers, but also the type and the mode and mobility that we need in terms of that provider type. And again, existing providers were 100 or 202 existing active providers in the network. We are always active in trying to grow existing providers. We're currently offering incentives to them to promote expansion, and that includes, that just includes paying more per mile and base rate increases to help offset some of the increased costs that the provider network is experiencing due to the pandemic. Another strategy that we're working on, and this, I believe we talked about this last time as well, there was a survey that went out that 2 nursing facilities that asked whether they would want to be a transportation provider. We've got some good feedback from that, and we have begun the process of enrolling some nursing facilities to become transportation providers. And Cardon is one that we're actively working with right now. There's others that we are in the process. And this is just a great program and a great opportunity for nursing facilities as transportation providers. There's a lot of benefit there, and we feel that this will help strengthen the transportation provider network. Again, our facility outreach folks are constantly working with facilities to identify transportation needs. And again, this is an opportunity to resolve some of that through the transportation from nursing facilities. And then launched last year at TNC's transportation network companies, think Uber and think Lyft. We're partnered with Lyft in the state of Indiana to provide transportation. Started back in September of 2020. Again, they're a provider of last resort. We're only using them in a very limited capacity when it's appropriate. We have an API which is just a computer programming interface between our systems and the Lyft platform for scheduling rides. That's automated, so there's little manual data entry between the two systems. But since September, we've had a total of 3,600 trips on the Lyft platform, about 900 members in 31 counties. It's less than 1% of the total volume. And really, when we started with Lyft, they were in, I think it was 164 zip codes within the state, and they've also seen impact from the pandemic, and they are down to roughly 60 zip codes. So even capacity there is limited, and again, we're just using them when we need to, as needed. We would prefer to use a traditional transportation provider when available. Next slide. This slide talks a little bit about ALS and BLS providers. I want to focus on the stretcher side, actively recruiting for wheelchair providers, and working to increase the capacity of wheelchairs. Again, what we're seeing in this area as well is rise in insurance costs, labor, and fuel. And again, to mitigate that, Southeast Transit partnered with another broker to help establish an insurance entity to provide insurance specifically to NEMT providers. And we are actively providing rate incentives for providers to overcome the challenges in recruiting and obtaining drivers and paying for increases in fuel costs. So we are working hard to ensure that we've got a robust network in Indiana. On the outreach side, I think we may have spoke too soon and may have jinxed ourselves a little bit, but we talked in April, we started resuming on-site facility visits and thought folks are vaccinated, we'll be able to get out more, and we've been cooped up, and we really wanted our facility outreach managers and coordinators to be out working with facilities, and that face-to-face conversation. And we've been doing phone and we're doing Zoom today, but I think everyone agrees that those face-to-face conversations are key, and we really want to get out there. Not sure where the Delta variant is going to land and if we're going to be able to continue, but we're getting out there and meeting with providers where we're able to. We have quarterly workshops. Next one is set up in August. A lot of times, we're talking about the program as a whole, but we're also talking about the technology, the facility portal, and ways to make it easier for social workers and facility managers to work with us to schedule transportation. We're going to be at 2 conferences later this year, one in August, one in October. Again, more community outreach from the facility side. One of the things we're doing on the transportation side is we are now, we're back to town hall meetings for transportation providers. Again, the Indiana one is planned for September. We may need to adjust depending on where we are with the pandemic, but we've been doing this as an enterprise in other states. We started in Louisiana, we've done Tennessee and Virginia, and these are great opportunities for us as the broker to meet with the transportation providers. Again, it's been a while for those face-to-face conversations, but it's an opportunity for us to set the expectations with the transportation provider, to talk about the appropriate sendback process so that members aren't being turned away at the last minute. We really focus on making sure transportation providers understand the importance of the services that they're providing. We speak to them again about our expectations, but we also talk to them about growth and growing their business and things that they can do in areas in which we could use them in different counties throughout the state. So it's an opportunity for us to express our expectations about the program to them. It's also an opportunity for them to ask questions of us and talk to us about challenges that they're seeing. It's, I think from what I've seen and experienced in Louisiana and Tennessee, we learn just as much from the providers as they learn from us learning these. So we're really looking forward to getting out and meeting with the Indiana providers later this fall. Next slide. So the next few slides talk a little bit about some of they're called member experiences, but really these are some of the events that occurred within the network since we last spoke. And there's 2 that I really wanted to highlight here, and it really speaks to the partnership and the collaboration between the broker, the healthcare facilities, the member and the agency. And the first one here was a child in Clark County who needed BLS transportation. And it was a long distance trip. And we had an EMS provider who we partnered with who was willing to transport that member long distances. The challenge was the availability wasn't always there. So lining up the medical appointment with the stretcher vehicle or the BLS vehicle to perform that trip was a challenge. So we worked with the transportation provider, the EMS company. Our team worked with the member, and we worked with the hospital to ensure that the member was transported and seen. We provided dates that worked. We basically coordinated calendars and made sure that there was availability on those days, lined everything up, and really, walked through the process with everyone to ensure that that member's transportation and, more importantly, their healthcare was provided in a secure manner. The next one I just want to touch on real quick is the fourth one on that list there, and this is one that we're really proud of. This is one of our drivers. This is a Southeast Trans QRV driver who regularly transported a dialysis member. And member was in a wheelchair. And one morning when our driver arrived, knocked on the door like they usually do to pick up the member, member didn't respond, did not come to the door. Our driver again knocked and this time heard the member, but faintly through the door and quickly realized that member was in distress. Our driver then called 911. EMS arrived, basically kicked in the door and found the member had fallen out of the wheelchair, could not get up, and basically came through and worked with that member to ensure that they were safe. So that's something that we see not often, but we do see it. We do have a program as part of our mobile technology. It's the member care program, and it's a way for providers to and drivers to report things that they see. This one obviously pretty dramatic, but typically, our drivers and the drivers within this program are with members more than sometimes family members, and they see things, and we give them an opportunity to report those to us. They come back through us electronically, and then we review and make sure that they are appropriately taken care of. This one, again, a little bit more, a little different than what we typically see. But again, our provider network is doing great things out there, and we just wanted to highlight a few of those experiences. Next slide. And this slide here talks a little bit about our community engagement. The vast majority of the employees who support this contract, work and live within the state of Indiana. And as being part of the community, one of the things we do is community outreach. So there are a number of things here listed that we've done. We wanted to highlight this Wheeler mission engagement, the first one listed here. And this one actually, this community engagement, this volunteering opportunity actually came from a visit to the site to talk about transportation and what was going on with transportation there. This is a rather large facility with a number of people within and outside the facility, which sometimes makes it difficult for transportation providers to know where to go to pick up folks, and that can make it difficult for on-time performance and for transportation in general. And what Wheeler had done and what we had worked with and talked to them about was they basically had created some pickup and drop-off zones very similar to an Uber or Lyft zone at an airport or a stadium or concert venue that made it easy. It was a centralized location for members to be picked up and dropped off at. But while we were there talking about transportation needs, we saw an opportunity to volunteer. Sandy and her team here in Indiana went out, volunteered, served food, served drinks, helped clean up, and really just had a great time out serving the community. They're going back later this year, I believe in October, to do it again. And again, just wanted to highlight some of the community engagement that Southeast Trans has here in state. Next slide. Oh, I think that's it. That's it for me. Elizabeth?
Jim, before we move on to Elizabeth, we have a couple of questions in the chat. Lindsay, is it okay if I have Jim address those?
Please.
I'll just
Take the second one though, sorry.
What's that?
I'll take the second one.
Very good. So Kristen asks, is there a possibility of giving wheelchair vehicles directly to providers to expand that capacity to existing providers?
There actually is, in not necessarily giving free, but there have been instances in the past where we have provided vehicles to transportation providers, interest-free loans to get them up and running. And any provider interested in bringing wheelchairs into the network, we'd be willing to talk to you about that program.
Wonderful. Thank you, Jim. And then the next one for Lindsay. Why are you using Lyft as last result?
Sure. So when we enrolled Lyft in the program, Lyft requires kind of a different skill set on the members too. The members have to be completely ambulatory. They have to be able to get themselves to the vehicle, in the vehicle, out of the vehicle. They have to be able to help the driver get to them if the driver needs directions or something like that, where our typical NEMT providers don't. So the member has to kind of, quote, qualify to be eligible to ride and Lyft. And so there are a list of questions that are asked of each member. They have to agree to ride with a transportation network company such as Lyft as well. And so if the member meets all of those conditions and there is no other NEMT provider that is able to transport them, then we'll transport them with Lyft. If we gave Lyft all of the transportation trips that an ambulatory person schedules, then that would, devastate our NEMT provider network as well. And so we would lose drivers, we would lose providers in the NEMT program because they wouldn't have enough volume to support their business and their insurance needs, et cetera. So those are the reasons why Lyft is provider of last resort, but that's only, everyone needs a trip. We want to provide a trip for everyone. So if we don't have a transportation provider for them in the traditional network, then we will go to Lyft so that they won't get Lyft or they don't get any NEMT traditional providers.
Thank you, Lindsay. I have a couple of more questions and then we will move to Elizabeth. Kristen also asks if change in condition status is shared with Medicaid or case managers, specifically from the drivers.
Sure, I can take that too. So when the information from the drivers is reported to SET, we have quality calls with SET weekly, and that information is transferred to us. And then we are able to provide that to our clinical team for follow-up and for care coordination or management.
Thank you. The next question is from Gary. He wants a little bit of elaboration on rate incentives for ambulance providers.
So we're looking currently at mainly wheelchair and ambulatory, but are willing to talk to ambulance providers as well. What we're looking at and what we've seen in every state that we're in is that there are headwinds to transportation providers. There's increased cost for PPE, there's fuel cost, insurance cost, and then obviously driver hourly rates have gone up. So we're looking at ways to help transportation providers offset some of those costs. And we've been analyzing rates here in Indiana as well as other states and adjusting accordingly to ensure that we can fulfill those trips and have a network to be able to fill those trips.
Thank you, Jim. Senator Becker is asking about the time for authorization for hospitals, like that would be in line with what nursing facilities are allowed.
And I'm not sure there is a difference between the two. I believe it's still a 7-day, but I can check Senator Becker to make sure that is correct. But I believe
we'll make sure to answer that question and get that back to you, Senator Becker. And then 2 more questions, and then we'll move to Elizabeth. So Sherry asks if skilled nursing facilities are included in the member surveys.
I don't believe they are. I think for the automated calls that go out, we are not including nursing facilities, nursing homes in that, mainly because we would be potentially calling them multiple times a day for a survey. So I believe we're just looking at a traditional residence for those surveys. However, if there's an opportunity to survey them directly another way, similar to what we did last year with nursing facilities around transportation, we're more than willing to do that and could work with FSSA to come up with the appropriate, or even work with nursing homes and FSSA to come up with the appropriate questions for that survey. That's a great idea.
Thank you, Jim. Maureen shares a comment. And so Maureen, on comments about specific provider and member experiences, if you can share that specific information back with our team so that we can look into it, that helps us continue to improve the program. So please send that. Thank you so much for sending that along. That will help us quite a bit. Sherry also has a question, and Sherry, we will take that back on slide 11 and answer that question and get that back to you as well. And then one more question from Sherry on credentialing for LIFT. Actually, this is a question that I think we've answered in a commission meeting before, but we'll share it again for our new members on credentialing standards for our different types of partners.
Sure. So Indiana has a TNC statute, and we followed the TNC statute along with those credentialing requirements for that. So it is a little bit different, and that's why members have to opt into using LIFT, because they're educated on that up front.
Thank you. Oh, and then I missed one from Gary, and then we'll Elizabeth, I promise we'll get to you. Gary asked if we are accepting 1,500 forms electronically.
Yes. Yes, there's an opportunity to upload those through our provider web portal electronically versus mailing those in.
Great, thank you. Thank you all for your questions. And now we'll turn it over to Elizabeth. Thank you.
Good afternoon, everyone. For those who have not met me, I'm Elizabeth Darby, the Director of Vendor Management for Indiana Medicaid. I oversee all of our administrative contracts and our vendor managers, and I'm also very closely involved in the Nemt contract. As Lindsay mentioned, I do meet with SET twice weekly, once to review data and once to review quality assurance and member issues. And I also have bi-weekly meetings with our Nemt State Director at SET. Today, I'm going to show you the pay for outcomes results for the contract year 3. As a reminder, SET has a unique contract year. Their contract operates from June through May of the year. So you will see quarters. Those do not add up or correlate with calendar quarters or state fiscal year quarters. They're unique to this contract. First, what I'd like to do is just outline the contractual framework for the pay for outcomes process. We do use pay for outcomes across other vendors as well, but each set of pay for outcomes standards is unique to the vendor and the contract year. The broker's contract includes the criteria that are monitored on a quarterly basis. Again, my team and I actually meet with SET weekly to review data, but the data you will see is all quarterly. 3% of the contract value that SET is given is withheld and must be earned back according to meeting or exceeding the performance metrics. The broker must be in good standing with the state in order to receive earned payouts. This means they cannot have any formal corrective action on this contract or any others with the state. And the Nemt Commission must approve the annual payout based on the performance results. This is a contract clause unique to the SET contract to ensure that your voices are heard and you get a vote on that. Lastly, the funds are paid out once per year and they do not roll over. So what they don't earn or aren't approved for is done, and we'll start a new year, which started on June 1st. For the Nemt contract, we break the pay for outcomes into 8 categories. The first category is quality. The second is safety. The third is transportation scheduling. The fourth is transportation requests. The fifth is provider services. The sixth is member education. The seventh is encounter data, completeness, and timeliness. And the 8th and final category is report accuracy and timeliness. I'm now going to go through each category and show you the metrics underneath and the quarterly score that SET received in the last contract year. For the first measure, quality, there are 2 metrics that must be achieved. The first one, no more than 1% of completed trips shall have an associated valid member complaint. This does not mean substantiated. This does mean valid in that it relates to fee-for-service and they are eligible for SET services. So all of those complaints that Jim showed you earlier on the first column of his chart. The 1% is the metric. In the first quarter, SET had a 0.05% complaint rating. In the second quarter, they had a 0.14% complaint rating. In the third quarter, they had a 0.12% rate. And in the fourth quarter, they had a 0.15%. This means they met the criteria for all 4 quarters on that metric. The second metric is that the contractor must investigate, remedy, and close 95% of complaints within 15 days of receipt. They have closed 100% of their complaints within that 15-day period. Again, they do meet with me weekly to ensure that if we have any concerns or don't feel that they've remedied the situation fully, that we will have them leave it open or continue to work on the issue. Again, they are eligible for all 4 quarters. That gives them a total available payout of $92,850, all of which they had earned. I'm going to go on to our next category, which is safety. I apologize, this text is a little bit smaller to fit it on one slide, so I will read them out more concretely. The first metric is that 0% of vehicles used for transport will be out of compliance. Out of compliance consists of being overdue for inspection, or if a vehicle is removed due to compliance but is still being used. They can have 0% out of compliance. They have passed that measure all 4 quarters. This measure, we do not do a report out. It is simply pass fail, as you'll see with the rest of the criteria as well. On the set gate metric, the contractor will conduct random unannounced spot inspections. They did pass this measure. Some of this was put on hold due to safety issues because of the public health emergency, but they have passed for all 4 quarters. The third metric is that they will conduct 75 separate wheelchair segment inspections. Again, they did pass all of that for the year. And the last one, 100% of transportation provider drivers who provide services in a given quarter shall meet the contractor's licensing and training requirements. The metric is not met if a driver is out of compliance during a random audit, or if a driver still provides services after discovering that they were non-compliant. They did pass on all of those measures. The safety measure is valued at $139,275, and they are eligible for a 100% payout. We'll now move on to our next measure, which is call center. This is our largest measure as far as metrics, so it does continue on to the second slide, and I will come back so you can see the payout when I finish. For this one, 100% of calls shall reach the call center menu within 3 rings or fewer. They have met that standard on all 4 quarters. The second metric, quarterly average speed to answer a call, that's when you actually speak to a person, shall not exceed 60 seconds. You will see that their call center has extremely good response time. In the first quarter, they had a 35-second average wait to talk to someone, 30.3 in the second quarter, and then it dropped even further, 25.67 seconds and 23.33. This is a really remarkable call center performance. I see call center performance from several of our different vendors, and SET's call center is far and above one of our most responsive and outperforms a lot of others. The next measure is simply that they cannot have members receive busy signals. They didn't pass that measure. The fourth measure relates to abandonment. This is hangups. The quarterly lost call abandonment rate shall not exceed 5%. And in no calendar week shall the abandonment rate exceed 7%. You will see on this, they did not meet the metric for the first quarter. Their abandonment rate was 6%. They did not meet it in the second or third. They were just above 5%, but they did meet it in the fourth quarter with a 3% abandonment rate. Continuing with the call center, an answering machine, voicemail, or answering service must be available for after-hours calls, and 100% of after-hours calls must be returned within 1 business day. They have met that performance measure all 4 quarters. The sixth metric, 85% of all issues from callers should be resolved on the first call based on random monthly call center surveys. As Jim mentioned, that is one of the questions that they do ask on those random surveys that come out. They had a 94% success rate on this measure in the first quarter, 94.88% in the second quarter, 94.85% in the third quarter, and 96.91%. The last metric for the call center is that the contractor must direct 100% of requests for 911 services or emergency requests to 911 or an appropriate ambulance service. This metric is a yes, it is 100%, and they actually did not have any emergency calls, so it is more of a pass-fail than a yes measure. I will go back up to the top so you can see the amount that they are eligible for on this measure. Again, they are eligible for $139,275, and the earned payout is $87,046.75. Moving on to our next measure, transportation requests. OMPP and FSSA have a very high standard of level that we expect for transportation requests, so you will see that below. The first metric, the contractor shall employ an auto routing system that assigns 90% or more of requested trips within 48 hours. They did pass this measure every time. Their auto routing system is in effect and very efficient. The second metric, the contractor shall furnish appropriate transportation as outlined in the contract for at least 90% of valid transportation requests. In this measure, they did not pass or meet the standard in any of the quarters. They rated at 88.29 in the first quarter, 87.09 in the second quarter, 85.72 in the third quarter, 86.39 in the fourth quarter. I will note that this member transportation request is the larger number that does include member no-shows. So if you refer back to the slide earlier where Mr. DiViumberto explained that member no-shows, if you take that out, they have a much higher success rate. However, we hold them to the higher standard for the performance measures. Because they did not meet that 90% rate minimum, they are not eligible for any payouts on this measure. Transportation scheduling. This is the opportunity to get the trip coordinated, not the trip itself. 0% of scheduled trips shall require the member to board the vehicle prior to the scheduled pickup time based on member complaints and survey responses. This excludes members who ask to get picked up early. Occasionally a member might prefer to go. They might have meal times that they're trying to get around or things like that. But of that, they have a 0%, which is exactly what they should have, and they meet the first metric. On return pickups, 95% of return pickups from their appointment shall occur within 1 hour of the time of notification to the contractor. This is a pass-fail, and they did pass that measure the first quarter. We then started tracking it at a percentage level in the second quarter, and it was 94.39%, 99.24%, and 98.9% in the fourth quarter. So they did not pass in the third quarter or the second quarter for this metric. The others they did. On the third metric, the contractor shall allow transportation providers to load multiple passengers in the same vehicle at the same time, including passengers who are not members. This is a pass-fail, and they did pass this measure. Number 4, 90% of trips shall, regardless of traffic or road conditions, shall deliver the member on time for their appointments. This is, again, a 90% rating. They passed in the first quarter, and then we again adjusted their reporting to get firm percentages, and they reached 80.06%, in the second quarter, 95.12% in the third quarter, 94.84% in the fourth quarter. So again, in the second quarter, they did not meet this metric. The final two are pass-fail measures based on their contracts with transportation providers. The first is that transportation providers notify members of anticipated tardy pickups. This is not a tracking of the notification, it's a requirement of the provider to do so, and that is a contractual piece between SET and the individual providers. They passed that measure. And the second is a requirement that providers notify medical service providers of anticipated tardy drop-offs or arrivals. Again, that's a contractual obligation that SET has to have it in their contract, and they passed that measure. For transportation scheduling overall, SET is eligible to earn $139,275, and the amount that they did earn was $121,865.63. Our next measure is provider services. This is really about claims and payment, as well as the regional support that the state needs and ensuring an adequate network. The first metric, 98% of claims paid within 21 days if they're an electronic claim, or 30 days if they're a paper claim. They met 100% the first 2 quarters, 99.8% the third quarter, and 99.84% the second quarter, or the fourth quarter. The second metric, 70% of claims submitted electronically. They did not meet this measure for any of the quarters of the calendar year. And as you will see, they are quite a bit lower. We are seeing some good progress in this area, and it is a point I will note for you that my team is paying particular attention to and speaks with SET on every week. The third metric for this measure is detailed regional gaps report submitted and approved. Every month, SET must submit to my office a detailed regional gap report. It has to pass our standards and meet approval. They have done that every quarter. That means for the provider services, they are eligible for $139,275, and they earn $69,637.52. Our next measure is member education. The contractor will attempt to contact and educate all members who do not appear for scheduled pickups, no-shows, within 5 days of the occurrence. They have passed on that measure in every quarter of the previous contract year. The second measure is to reduce member no-shows. Not only does it mean that members are not getting to the doctor, but it is also a very difficult situation for providers and can limit transportation options. SET works very closely to reduce member no-shows, and their target was to reduce it by 20% from the level measured in the contract year 3. They reduced the level for quarter 1 by 27.04%. In quarter 2, they reduced it by 40.18%. In quarter 3, they reduced it by 22.61%. And then in quarter 4, they did not pass. The no-show rate actually went back up by 20%. In this measure, they are eligible for $46,425, and they earn $40,621.87. The next measure is encounter data, completeness, and timeliness. Encounter data, just for those of you who might not be familiar with that terminology, is the point where a Medicaid member and a Medicaid service connect. That's what loops everything in our information systems and also allows for billing to occur. They did return all of their encounter data on time, and they passed for that measure. That measure is eligible for $46,425, and they're earned 100%. Report accuracy and timeliness. There are 2 metrics. The contractor shall furnish all reports on or before their due date. This includes any reports outlined in the Senate Bill 480 legislation, as well as other reports that OMPP requires them to submit. They did pass for quarters 1, 3, and 4, but they did have missed reports in quarter 2. And then the last one is the contractor shall furnish all reports accurately so that resubmission does not need to occur. Again, they passed for quarters 1, 3, and 4, and we did have to return reports and have them resubmitted in quarter 2. Overall, this measure is eligible for $46,425, and the earned payout amount was $40,721.88. This is a summary of those payouts and the total available and the total amount earned. Again, it is 3% withhold of their contract. And I will now turn it over to Dr. Sullivan for discussion.
Thank you so much for walking us through the pay for outcomes metrics. If the commission members have questions about any of those items, please unmute your microphone or alternatively raise your hand and I will call on you to ask your question. I will give just a few. Senator Becker, you have a hand raised.
Yes, I was wondering, could you email all of these slides for us?
Absolutely. We'll email and post. These will be available as well on our website for your review and future use as well. But yes, we will make sure that they are available to you electronically too.
Thank you.
Of course. Thank you. Other questions on Elizabeth's discussion of the pay for outcomes metrics?
I do have one question on, this is Gary Miller. Regarding the fulfillment, so am I to assume from reading these that 10% of requests are not fulfilled, or am I missing something?
We use the terminology missed trips for that. So 10% are missed trips. They come in for different ways, but ultimately the person did not get to the doctor at the date of the original schedule.
Gary, I think if you look at one of the slides at the beginning that showed the table that had the unfulfilled trip requests, and it broke it out by member related issues such as a member no. So if a member calls, schedules a ride, we book a trip, we send a provider. If the member cancels at the door, if they're a no-show, that is a unfulfilled trip and is in that top number, that 86% for the fourth quarter.
And on that breakdown from that earlier slide, I didn't see when SCT wasn't able to line somebody up. How was that tracked?
That would be an unfulfilled trip. So if we are, a member calls in to schedule a ride and we are not able to find a transportation provider, we've exhausted the network, we've tried our QRV drivers, we just cannot find someone to take them. That is canceled as no provider available, and that is tracked, and that is in that in both of those numbers. I'm sorry, yeah, in those numbers there.
It's included in it. It's not broke out separately.
No. We break out those that are kind of in our control and out of our control. So if we cancel a trip because the member's in the hospital, that's kind of out of our control. We can't control that, but the no provider assigned is something that is in our control.
And what number is that's in your control that are not fulfilled?
We are fulfilling 95.4% of those that are in our control.
Okay, so just less than 5%.
Yes, in the fourth quarter.
Okay, thank you.
Other questions for the pay for outcomes discussion? Hearing none, I will turn it back over to Elizabeth for a roll call. We do have voting and non-voting members for the pay for outcomes vote per the legislation that established our commission. And so, Elizabeth, if you would run the roll call vote, please. This will be a yes to approve the pay for outcomes and a no to not approve the pay for outcomes vote. Thank you.
Thank you. I will go through in the order listed. I know we have a couple of substitutions. I'm going to ask everyone in case someone joined while we were not there. Because I am using Zoom, I will use a plus sign for yes and a negative sign for no. For these purposes, we will update it with full yes, no at another time before we send the slides out. Philip on behalf of NR.
Yes,
Yes.
this is Philip, yes.
Well, it is not going to let me write on them, so I will write
Hey,
them on.
Elizabeth, I will track it on my list.
Thank you.
You'll just run through it. Thanks.
Dr. Kaufman,
Yes.
Mr. Miller,
Yes.
Mr. Van Zee,
Yes.
Mr. DiGiamberto.
Yes.
Do we have someone from the ARC of Indiana? Okay. Mr. Fry? Ms. Hampton?
Yes, I'm sorry.
Ms. Lace?
Yes.
Maureen on behalf of Fresenius.
Yes.
Dr. Sullivan.
Yes.
And then our representatives and senators, you are in an ex officio status as noted on the scorecard.
Thank you, everyone, for your participation and your vote for Pay for Outcomes. This Pay for Outcomes is awarded to SET, and we look forward to continuing to track improvements across all of these important quality metrics. Thank you specifically to Elizabeth and Lindsay for your leadership and organization around this work, and thank you to Jim for your partnership in this very important program. Next slide, please. Again, I would like to express my deep gratitude for the engagement of a multitude of the provider communities, our hospital systems, our ambulance services, our NEMT providers, our partners across state government and in the healthcare community, and as well, and primarily for the patients and the members that we serve through all of our programs. This level of engagement and attention to health outcomes is exactly what I would expect and hope from Hoosiers. And in addition to that, what I really love about the Hoosier State is our ability to really rally around complex and important and difficult problems and come together to solve them. We still have a lot of work to do to continue to serve our Medicaid members in this way. And I think we've made some great strides with all of your input and your voices to get this done and get it done well. I see a hand up from Senator Becker. Thank you.
Dr. Sullivan, I just wanted to wish you the very best and thank you for your service to the state of Indiana.
Senator Becker, I am so grateful to you and for your ongoing voice and your heart for this service and the heart for your constituents. We always know that when you talk, it's because you're thinking about the people that have asked you to lead for them. And I continue to be very grateful. We continue to grow because of servants as yourself who keep showing up and helping us get better. Thank you for your partnership and for your voice. And to all of you. This is one of the, I think probably the highlight is taking a really big problem with lots of people and lots of voices and coming together to try to make it better. And you all are definitely the manifestation of that. This is the best thing I've ever done. What an incredible role to play. And thank you for the opportunity to have it for so long. I'm grateful to Dan for stepping in, and of course, grateful to Michael Gargano, our Deputy Secretary, for staying on and his incredible service to Indiana. And thank you to all of you. And it's not goodbye, but see you later. Thank you so much and have a wonderful afternoon, everyone.